Assalamu alaikum and a very good evening, everyone. I am Dr. Amna Umar, Assistant Professor Medicine and Consultant Endocrinologist at Allama Iqbal Medical College, Lahore, and Executive Member, Pakistan Endocrine Society. I welcome you all to the second scientific session of Pakistan Endocrine Society Annual Conference. Today, we are here to discuss a critical and often overlooked intersection in healthcare, the link between diabetes and dementia, a double trouble duo that profoundly impacts the quality of life. Pakistan has an estimated 1 million people living with dementia. Each of diabetes, hypertension, high cholesterol, and smoking are associated with a 20 to 40% increased risk of developing dementia. Pakistan Endocrine Society, Pakistan Society of Neurology, Pakistan Psychiatric Society, and Pakistan Society of Internal Medicine are working in collaboration with 5Ds project, which is Deciphering Diagnostic Dilemma of Dementia in Diabetes Management. Before inviting our esteemed speaker, I would request our worthy chairpersons to please come on the stage and chair the session. Our first chairperson is Professor Dr. Javed Akram. He is former Health Minister Punjab, former Vice Chancellor University of Health Sciences and Shaheed Zulfikar Ali Bhutto Medical University, former Principal Allama Iqbal Medical College, founding President Pakistan Society of Internal Medicine and International Advisor to Royal College of Physicians London, and a well-known global researcher. Sir, please come on the stage and and chair the session. I will now invite Dr. Aisha Sheikh. She is consultant endocrinologist at Aga Khan University and a recognized tutor at University of South Wales, UK. She is currently holding the office of the President of PES. Next, we have Dr. S.N. Noman, who is consultant neurologist at Mayo Hospital, Lahore, and he is executive member, Pakistan Society of Neurology. Do we have Dr. S.N. Noman in the hall? Yes, we have. Our fourth chairperson is Dr. Mushtaba. He is executive member, Pakistan Psychiatric Society, and he is head of Psychiatry and Behavioral Sciences Department at Gulab Devi Hospital, Lahore. Now, to enlighten us with his thoughts and experiences on dementia and diabetes, we are privileged to have with us Dr. Abbas Raza, who has an extensive list of achievements and contributions to his credit. Dr. Abbas currently holds the office of President, International Society of Endocrinology. He is executive member and past president, Pakistan Endocrine Society. He is past president, South Asian Federation of Endocrine Societies. He is founder, president, ACE chapter of Pakistan. He has been awarded Lifetime Achievement Award by PES and has recently received International Excellence in Endocrinology Laureate Award for his outstanding contributions. Please join me in welcoming Dr. Abbas Raza to the stage to shed light on dementia and diabetes. Thank you.
Assalamu alaikum. I hope everyone can hear me. Actually, I don't know if the speakers at the back are working because thanks to the efforts of the organizing committee of Pakistan Endocrine Society, we are not only houseful, but I think we are beyond houseful. Wonderful work done by Faisal. I don't know if he's in the room or not. Oh, there he is. There he is. Thank you, Faisal, for making sure the house was not only full, it's overflowing. And again, Ali, Ibrar, Aisha for putting up a show which is outstanding. Actually, the next, the one thing that I must appreciate for the people who are sitting at the podium as well as in the chair positions is that in the next 5 minutes, it's not going to be a scientific meeting that we are talking about. It's about some endeavor that we have taken over in the last few months in Pakistan and how we've been able to carry this along in Pakistan. And I think this is very important for the fact that things can be done and things will be done in this part of the world, knowing that we can work together and make things happen. So one project which was very near and dear to my heart, and again, I must tell you a little bit story about it. We are all busy in our clinical practice and we all worry about different disease process. But one thing we tend to forget and one thing that we sometimes misread is the complaints, subtle complaints of patients which they come and ask us. And one of the biggest complaint, honestly, I have to admit myself, the biggest complaint that I've been missing out in my clinical practice is people coming in with problem in memory, in cognitive disorders. And the reason I say this is such a vague campaign that anyone and everyone who comes to you talks about two things. And people who are here from outside Pakistan, there are two things which are very common in Pakistan. One is a gassy bloated abdomen. The other one is not being able to remember things the way we should remember. So that problem in itself sometimes helps you realize that if you don't, and there's a common proverb in English which says that your eyes don't see what your mind doesn't know. Honestly, cognitive disorder in diabetes is one of the most underdiagnosed and most undertreated problem in this part of the world, because we, number one, don't know how and when to look for it. And the second biggest problem is when we are even looking at it, we don't know what to do with this. So the whole concept of 5Ds, which was deciphering the diagnostic dilemmas of diabetes, dementia, came from that idea. We needed to look into what the problem is and how to deal with that problem. And I think that's that. And when you try to do something which is for the beneficial patient, I believe that people join, things move on. And again, the concept and just the presence of these esteemed people on the stage tells me that whatever we decided to do kind of worked out. So let me take you through the journey of what we are doing, what we have achieved till now, and what are we going to do about it in months to come. And I think that will be something. So the whole concept started actually a couple of years ago for me, but actually the transformation, or actually rubber meeting the road, started somewhere in May, when we first I did a talk on dementia and diabetes in the summer retreat in Nathia Gali this year. And I got the attention of a lot of people there, along with my friends who were presenting at that time. So the whole month of June, July, we kind of got together. We took the initiative, Pakistan Endocrine Society, Pakistan Society of Neurology, Pakistan Psychiatry Society, Pakistan Society of Internal Medicine. Who do you see at our podium? Nicely got together and decided to do something good. And we wanted to do something concrete, something which was actually tangible and was able to continue it over a period of time. First part was getting the task force in place. And again, task force from all these four societies got together, came up with the infrastructure of how you would want to do. And the first step in recognizing the disease process was realizing that we need to look at the international as well as the local data on cognitive disorders and diabetes. So this is the first stage of what we are going to do in years to come, working together. Obviously, the first skeletal of the whole guidelines came into existence at the time. We had our first meeting in August, when we looked at the infrastructure of that guidelines, and we kind of looked at the people and what their contribution was. I think for the first time, I've been doing this for a very long time in Pakistan, and I think for the first time, it was a very proactive and interactive session in which all the experts looked at the document in detail, they gave their input, and they were cross-questioning among the people regarding the write-up of that is concerned. We were blessed to have the people who were helping us in scientifically writing it correct, and they were present at the same time too. So we all got together in Lahore and came up with these guidelines. What is the future? We have, since that input came out, we got together, we came up with the information, and we have written down a document. I don't want to disclose too much about it because it's an extensive document. And I was looking at the slides that I was supposed to present today. If I wanted to go over the whole document, it was more than 100. And I don't want to bore you and limit you from the dinner. But I am going to discuss some of the key elements and key points of what we are going to do in this study. And I will encourage all of you to at least go through it. We're going to concise it, and we're going to present it to you. And obviously, the way forward is publishing it. After publishing it, we are going to look at the recommendation and probably follow up with what we are going to do as far as the cognitive disorders are concerned. So let's look at the deciphering dementia and diabetes. So there are four components I'm going to briefly touch upon, and then I'll leave the podium to our leaders to help me guide what direction we should be taking and what are the information we should be taking home from. So the quality and the quality of the whatever we are going to whatever we're going to publish, I'm going to share some of the information on that. Etiology of dementia or cognitive disorders in diabetes, diagnostic methods, and obviously some treatment. So I'm going to just go over some of the recommendations we are coming up in this time. I'm not going to go over the literature research that we did. But I think the more important thing is we need to look at these task force and look at the methodology we used during this process. So we did our PRISMA guidelines. Based on the PRISMA guidelines, we looked at the literature research. We did the literature search in the more scientific way, and we tried to combine most of the international and local data, some of the glimpses you'll see in my presentation. We needed to not only look at the data, but we also needed to look at the scientific validity and the strength of these information that we could get. There were randomized clinical trials, there were cohort studies, there were case reports, there were research, there were expert panels, and we graded them according to whatever the recommendations were at that time. What were the key research? We looked at, again, doing the research, we did the diabetes and dementia, we did the dementia and cognitive impairment, prevalence, diagnostic methods, and management of these things. So the point I'm trying to make here is that let's start doing things more scientific. And I know they're flag bearers of the scientific world, not only on stage, but sitting right in front of us, in which we are looking at more developing this culture of science in this part of the world as well, as we go along. So this was just the PRISMA flow up that we did. We searched in the last 20 years what work has been done and what information can we get out of it. So without further ado, let me share you some of the analysis, some of the facts, and again, I'll run those things. So we tried to look at the prevalence of it. What are the prevalence? And I would again refer back to you once the publication is done, what was in it and what is the outcome of it. But we did look at the association of lifestyle and cognitive disorder. We looked at the prevalence of dementia among patients who were hospitalized. What was the impact of memory if someone was diabetic and was hospitalized? What was the impact of glycemic control over years? What was the impact of glycemic variation? If you had diabetes for long duration, what impact does it cause? If you had diabetes which had a lot of variability, what influence does it have in the memory? So we looked at multiple factors with it. Other interesting point that we actually found out, which there's not enough data when we were trying to tabulate, was what is the impact on the type 1? Because we know by definition type 1 is a little different than type 2 as far as the causative of it. But if you have type 1 diabetes for long enough, as for retinopathy we know, as for nephropathy we know, that the complications start trickling down. So again, we are looking at these type 1 and we found out there were few studies with it. And again, in a quick rundown of it, I'm showing you this, but the inferences you will see in the document itself. The other big question for us was to look at the local data. Unfortunately, just like most of the scientific, we are struggling, and this is not be the case in years to come, is the local Pakistani data on this subject. There was not many, and again, thanks to our panel of experts and the task force, they all pointed out that there was some study. Initially, we could not find much work, but then we found out there was some work being done, and I quote some of the studies here in which the number of the patient involved were not huge, but we were able to find these individuals. So in summary, what was the recommendation? It's not going over all data that we said. We said that we need, for cognitive disorders, we need to be proactive than to be waiting for complication to have. Because if you have cognitive disorder which advances a little too high, it's difficult to treat. Integration of lifestyle modification, tight glycemic control, and the use of medication could result in the outcome of how the cognitive disorders are going to present. Multidisciplinary approach. Unfortunately, we talk about diabetes management and the glycemic control and the management of diabetes in a better way. We would tend to forget. We can give 100 different recommendations however we want to, but in our clinical practice, sometimes we lack the ability of diagnosing and treating these individuals based on the fact we don't have enough time. And I think it's about time that we should start collaborating. We should start developing a system in which we have a multidisciplinary approach in treating different disorders when we look at it. And obviously, developing research, realizing the fact that although there were few studies done in Pakistan, we didn't have enough. So again, that's what the usual recommendation from the task force was, and you'll read more about it as we go along. Now, looking at the etiology of dementia, unfortunately, dementia is not only common in diabetes, it's common in multiple disorders too, and there's an overlap. Being a metabolic disease process in itself, I think there is a big problem in diabetes, because sometimes it's difficult to say, is dementia or cognitive disorder related to the glycemic variability or the poor diabetes control, or they have underlying hypervascular disease which is leading to that, or they have other metabolic condition. And as we all know, that diabetes is one of the endocrine disorder. And if you have one endocrine disorder, you're more likely to have other endocrine disorders as well. So again, that's something that you need to look at. So looking at the etiologies, it was sometimes difficult to decipher or to differentiate between different problems of cognitive disorders. So what are the etiologies in our part of the world? What are the etiologies of dementia or cognitive disorders in diabetes? We looked at diabetes and elevation. We researched all the causes of it. We looked at the variability and risk of dementia. We looked at the risk factors, including if there were other metabolic coexisting. So if you have diabetes and some other disorder or an endocrine disorder, what are your chances of developing cognitive disorder? Impact on liver disease and cognitive disorder along with diabetes. Other metabolic, iron, there's definitely some roles of metabolites in our part of the world which can make a difference as far as cognitive disorders is concerned. And obviously, we went through very extensive research work and tried to find out what was it. So what were the recommendations? And I'm sure I'll quickly share some of the recommendations with you. Is stable glycemic control. Based on the information, again, you'll find most of this information in the article as well. Glycemic variation is something which is very fashionable, very relevant, and this is something that we should all be looking at. With the CGMs now being available, it will be very important if we look at the variability and the glycemic control of it. Effective treatment. We tend to forget the sleep disturbances and effect of it in the cognitive disorder. So, do we ask about sleep hygiene? We listen about, again, there's so many times we end up prescribing antidepressants to these individuals, and we end up worsening their cognitive disorders and worsening their thought process as well. And again emphasizing the role of multidisciplinary approach in treating these individuals as we go on. Then, a very important fact as far as treating and taking care of diabetes is concerned is how to diagnose it. And I think there I would want to take a moment of your time realizing that the problem is sometimes not in you don't want to diagnose. The problem is you don't know how to and where to start. And I'll give you the best example. When I initially came to Pakistan, there was a lot of people had reluctancy in starting and diagnosing thyroid disease. And the reason was, if you thought of a thyroid disease, you would think of a thyroid scan, you would think of a TSH, you would think of an ultrasound, when a simple screening test which was required was a TSH. I did across Pakistan courses in which we found out that the people were reluctant because the cost effectiveness was not there in diagnostic testing. Same is true with that dementia and memory decay. We don't know where to start and what to do if someone is experiencing. So if you look at the cognitive tests that we talk about, if we look at the imaging techniques, if we look at the blood CSF and the neuropsychological testing, there's a whole list of it. And we as a group of experts decided to come up with some way or form to make the life for initial screening of these individuals easy so that we can help them treat better. So the recommendation was simple as, that, you know what? Use simple techniques first. Use mini-mental. Use any screening tool that you can use in the 5 to 6 minutes time exposure with the patient so that you can screen the test. And then probably use a multidisciplinary approach in helping it diagnose. So when it's time for someone to see a psychologist or a psychiatrist, we should refer it to the person initially after screening for the testing. We don't have to do an MRI on everyone. We don't have to do a CSF examination on everyone. We don't have to do a PET scan on everyone. Something that we need to be careful and what we need to do. Last but not the least, before I finish and give the mic back to our experts for their expert opinion and their journey in this process, what are the management? Diabetes and cognitive disorders are very important. We searched on the medication and the role of medication on the cognitive disorder, including the pioglitazone, the metformin, the DPP-4, SGLT2, and there is definitely data. But to differentiate the effect of the improvement in glycemic control and to have a solo effect of that medication was a little bit difficult of task. But we were able to differentiate, and in the article you will see a differentiation between the medication and the role of medication in cognitive disorders. It's not only the medication for diabetes. What about the medication for treatment of dementia in itself? What is the role of these medication like memantine, like amantadine? What is the role of these medications? This is part of our future project as well, to look at the role of these medications. Although the cognitive disorders are so common, but I don't know if I can have the raise of hand among the people, how many of us are actually writing those medication in the. We don't write because we don't feel comfortable, because we don't feel comfortable diagnosing it. The problem is we don't even refer to the people who can write it. So for most of the things, we have made protocols which is easy to treat. So someone has a heart problem, it's easy for us to have them a consultation by a cardiologist. But unfortunately, if someone is having cognitive disorders, we sometimes don't have time to screen for it. We don't have time for someone to actually look into it and treat. And we don't even refer it to people who can diagnose and treat these individuals. So something that as a group we thought was very important, and again, very relevant to our population to help us diagnose. So that's a recommendation. So that as a group, we came up with a recommendation that obviously there are certain medication like GLP-1s, there are medication like SGLT2, there are medication like DPP, which have shown to show some improvement in the cognitive disorder, but we need to look at it in Pakistani population and how they work. We need to look at the medication used universally for memory issues in this part of the world and help us define what's the role of them in Pakistani population. And again, this is one of the future projects of it. We are going to look at the memory medications to help people again. And obviously, customized treatment options for these individuals, multidisciplinary approach, referring at the right time and diagnosing at the right time. So these were the few recommendations from it. And again, here I would like to stop and say that probably wait for the article to come, wait for the consensus paper to come out, our recommendation, and obviously the meta-analysis we did on the research we have. At this time, I'm happy to be presenting at this time, and I'm happy to be sharing the stage with 4 different organizations. But important part is that if we want to work together, we can work together. And probably this event is the best example of it, where not only internal medicine, but not only endocrinology, not only psychiatry, but neurology, all of us are working together, and we're coming up with recommendations which are very relevant for our part of the world. I think the societies, again, I'll refer it back to, and I'll give back mic to the secretary of the stage. And I would love to hear from the presidents of the organization and see how do they look at this project, how do they find this in their clinical practice, and how do they find, what kind of impression that they have, how they will be implementing this guidelines, task force, and the meta-analysis in, and what future direction, which is more important, that you would like to see this project evolve into in years to come. Over to you. Thank you.
Thank you so much, sir, for such a comprehensive talk on dementia and diabetics, and giving us an insight into the 5Ds project. I would now request our worthy chairpersons to give their valuable comments.
My name is Dr. Ehsan Numan, and on behalf of the Professor Naila Shahbaz, she's the president of Pakistan Society of Neurology. First of all, I really appreciate the efforts of the whole team sitting here and the organization Nabi Qasim, that this event is literally very important for the rest of the world in Pakistan. As a clinician, I just need to comment only a few things. The guidelines should be very clinical. So because we have very reserved resources, we must use every possible thing to diagnose dementia in diabetes or any other diseases on clinical grounds. I will again repeat it. on clinical grounds. I will give you a very simple example. Our brain is roughly about 1200 to 1400 grams only. 1200 to 1400 grams only, and there are about 86 to 100 billion neurons in our 1400 gram brain. And the best thing is the synapses of these individual neurons, each neuron interact with each other about 10,000 times. So in this 1400 grams brain, Allah has given us more than 1,000 trillion synapses. So just for our understanding of the dementia, we have to improve these connections, these synapses. The first things, when we are patient of either diabetes or any other risk factors, they develop memory impairment. I will just give you 1 minute of the refreshing of the neuroanatomy. The Alzheimer's disease basically is the prototype of dementia because the temporal lobe affects the first. So to me, I have given a term to Alzheimer's disease is socially acceptable behavior. I will repeat, socially acceptable behavior is the clinical hallmark features of Alzheimer's disease. I will elaborate it. Patient will be behaved normally in our clinics, but at homes they are disasters for the families. And this is the classical pictures of Alzheimer's disease. The person who is disaster at home and disaster in the clinics is the classical case of frontotemporal dementia. The person who is very slow in initiating movements and finally develop the memory impairment is the classical case of vascular dementia. So in my practice, what we see is a vascular dementia alone or in combination with Alzheimer's disease is the most frequent dementia seen in our population. So I will recommend it should be diagnosed on clinical grounds and use the minimal invasive procedures. In full-blown demented patients, the MR is not possible. It's only CT scan that will help us to exclude other diagnoses. So I think the paper already they are made guidance, they're very effective, and hope we will make it more simple and easily available for our rest of the population. Thank you very much, sir.
Assalamu alaikum ji. My name is Mujtaba and I'm General Secretary of Pakistan Psychiatric Society. The most challenging part of dementia is the behavioral aspects which the patients present with. The problem the psychiatric patients have is that the dementia patients have actually is that they are unaware of the symptoms they are presenting with, and that presents a huge calamity for the treating physicians or psychiatrists or neurologists to actually understand the behaviors because they are unaware. And the family says that, okay, so we have a patient who, our father or mother is actually completely forgetting. They're not understanding that they have urinated or not. They have forgotten what they have eaten. Yet they would answer all your questions for the time being, especially in the start. All the questions they would be able to answer all the questions very appropriately. So it is very, very important for the clinician and the treating physician to take a collaborative history from the family to understand what is happening, and especially when you have mild cognitive impairment. If we can intervene then, the chances of going into dementia becomes relatively less. Also, the compounding factors like diabetes or other comorbid illnesses are also going to compound the behaviors of the patients, and sometimes we go into this groove that all of dementia is dementia and they need treatment, and if somebody is urinating on the bed does not mean that he does not have uncontrolled diabetes. It is extremely important that we have a collaborative approach so that all the sides of the patients are covered, since they are very unaware of what is happening to them, and since they are very unaware of the things which they're doing. So if we can manage in collaboration with the family members, and we can collaborate with each other at clinical level, then the patient and the sufferers and those who have the family caregivers will have a better life, and we can just lessen the burden of the illness here. Thank you very much.
Bismillahirrahmanirrahim. Thank you very much for bringing this topic up. Dr. Abbas Raza, I can recall when we last discussed about dementia and diabetes in our midsummer meeting, we were still at a stage where we did not know how this will evolve. But the document that you prepared, you and your team prepared, and then later on the meeting that was held in August, where teams from PSIM, Society of Neurology, and Society of Psychiatry were there. And that was such a fruitful meeting where we discussed each and every aspect of that document, and how we, being physicians and endocrinologists who are actually at the forefront of managing people with diabetes, at what stage we should be screening them for dementia, what tool should we be using, what kind of investigations that patient needs, and then at what stage that patient needs a referral to a specialist. And that was something afterwards that this document was later on developed, and there were useful discussions among us, the entire task force, bringing up new data, more evidence that was incorporated into the first write-up. And then with the help of, I would really say that I'm really grateful to our colleagues from Pakistan Society of Neurology and Pakistan Psychiatry Society that they developed a document, the way that patient will be screened and at what stage they need referral, that they simplified it so well that I'm sure when this document will finally be published and then disseminated across Pakistan, it will be a very useful, simple to use, where people working even in a primary care setup, secondary care setup will be able to manage their patients effectively. The other thing that is important from the perspective of people who are managing diabetes, it is essential that if we aim for a proper control, reducing all kind of vascular risk factors, we will be able to lessen the risk of incident dementia. And that is something that we have to think about, besides thinking about other microvascular and macrovascular complications that we often aim for. The other thing is that in Pakistan, we actually need, and this is something that PES has been thinking about and discussing about, but it's high time that we develop cohort of newly diagnosed people with diabetes, so that those cohorts can be followed up in a longitudinal manner, and we can then see how are we able to impact in terms of reducing complications, reducing the burden of complications, and improving their quality of life, and reducing the morbidity. So thank you very much for all the work that the entire task force has done under the leadership of Dr. Abbas Raza. It was a journey that I'm sure all of us really cherished and enjoyed. Thank you very much.
Bismillah Rahman Rahim and Assalamu Alaikum. Excellent effort. I think main credit goes to my younger brother who presented it so nicely and is conducting it so nicely, Abbas. I think he managed to get all societies together, and that is a very rare happening in Pakistan. Fortunately, we are all aligned and we are all thinking alike, and we are all learning from each other by working on this project. And I hope this is probably the first project where all the societies are working together, but not the last one, because collaboration, especially in a resource-deprived country like Pakistan, is extremely, extremely important to avoid duplication. Very nicely presented by again, the journey of dementia and diabetes. Obviously, it's an ongoing thing. The only thing that I was just thinking, what can I add to Abbas? I think two things. Since I'm biased a little bit. I was one of the presidents of Pakistan Aspirin Foundation, and we did conduct a small study where we used aspirin, low dose aspirin, um, for lacunar infarcts, which are very commonly resulting in dementia, and the outcome was better as compared to no aspirin for 3 years. So, and internationally also, I think aspirin has a low role, although it's different, the primary prevention, but here we are not talking of primary prevention. Here already the damage has been done, whether, like Numan said, vascular dementia or degenerative or senile dementia. So this is more or less secondary prevention to me for the vascular side, to give low dose aspirin. And definitely in our own meeting, when we'll have a meeting all together, we will try to look at the aspirin usage in prevention of dementia in diabetes, which is a condition where platelets are much more stickier than people without diabetes. We all know that. Another thing I think in diabetes extremely important will be to look at the prevalence and incidence and the severity of hypoglycemias, because we all know that many people are unaware of the approaching hypoglycemia. Hypoglycemia unawareness is a feature of, along with autonomic neuropathy and other problems, so many things that happen, especially hypoglycemia during sleep is a very threatening problem which could be prolonged, and that obviously can lead to a cognitive decline very quickly. And again, when I was doing a study on insulin, human insulin versus analogs, one of the things that was clear in that study was that the neuroglycopenic symptoms of hypoglycemia are masked if you are using analogs as compared to human insulin. So I think these things will also need to be looked at, that these patients, how vulnerable are they and how much they suffer from hypoglycemic events, especially severe, especially during sleep. And that will, I think, be one of the variables that we can look at in the long term, along with what such nicely Abbas put it up already. I'm very, very grateful again, Abbas, to you for this opportunity. I'm learning a lot from each other here, and especially you. And credit goes to you mainly for getting us all together. And also I'm very grateful to Nabi Qasim for supporting this idea and believing in all of us getting together, because in a country like Pakistan, it's not just the patient suffer, the whole family suffers when the patient is with dementia. And if there is anything we can do for these patients to prevent such a disabling disorder, we must all work together. Thank you so much.
I would express my profound gratitude to our worthy speaker, to our worthy chairpersons for their valuable comments. We would welcome any questions if there are any.
This is Nabil from Afghanistan. Thank you very much for a nice presentation. It was my privilege to attend your second presentation. It was a couple of years ago in Karachi. It was very nice as well. You reminded again those nice words of your presentation. And by permission of the jury mission, I have an appeal that if you are going to start this journey, give us the privilege, and it would be a good chance of us to be a part of your research in Afghanistan. We have 2 points, as I work in 2 sections, in private and public. If you could give us this chance to have a study the same as those patients they do not have maybe money or any visa problems to come to Pakistan, maybe to you visit them and also you put them in your trial. If it give us this chance that we do it there and also in collaboration with you, would we find a good solution in the future what to do? And my question is in here that from the point of vascular, if we are going to stabilize the vascularity point to the neurons, what's your idea, or if sometimes you use that coenzyme 10 in these patients, would it be beneficial or not?
Okay, thank you very much. And again, I not only remember you from our last meeting, but again, Thank you for being part of Pakistan Endocrine Society. Thank you for attending our meeting as well. It's wonderful to host you for again. I always found that the people from Pakistan, most of the doctors are right, and Wali Nasiri, who works with me very closely as well. So it's wonderful working with you. So to answer your first part of it, we will love to be we will love you to be part of our projects in the years to come. And again, I think I have full confidence in the other societies that we will love you to be part of any research product. um, I it's very important, again you brought up a very important part in what science has to do with the regional data, and I think it's very important that we need to get some local information, local data, if we want to come up with something. And again, Dr. Javed mentioned it briefly, but honestly, organizations, and again, it's not only one organization. For this project, it was Nabi Qasim. For industry to become part of scientific and science of medicine is very important. And if you look at this meta-analysis that we are doing, it has nothing to do with a drug. It has nothing to do with the medication. It's about awareness and bringing people. So it requires a lot of spine and backbone from an organization to support a project like this, which does not require any particular drug to be used, or it's just about awareness. And at this time, I would like to thank Nabi Qasim, and I think pretty sure Afghanistan could be a project of it. So answer your question on coenzyme Q10 and other modalities that we use in our, unfortunately, there's not enough evidence to support it. And again, that's very limited. And again, the problem whenever we are talking about meta-analysis or expert recommendation, and I started my conversation initially on the level of evidence we have. Unfortunately, I could not find enough, and as a group, we could not find enough evidence on vitamin supplementation on the efficacy of it. But that's something that we can look in our part of the world, if that is something we should be looking and probably promoting in the years to come. Thank you.
We can take only one question, one more question.
I have asked multiple questions. Actually, I take this conference as a challenge, and I make a preparation of 1 year to attend this conference. My question is not question. Actually, is the attribution to Dr. Abbas Raza. I done my graduation from Allama Iqbal Medical College in 2000, and now I am working as assistant professor at Gujranwala Medical College as a assistant professor of medicine. From 2000 and 2024, in my life, I met with teachers, and I grade their teachers into different categories. One is a teacher, one is a good teacher, one is great teacher, one is excellent teacher, one is exceptional teacher, and one is outstanding teachers. I work in a BHU in Pakistan, and I also have worked in USA in Temple University, Thomas Jefferson University, and I also work in state-of-the-art hospital, Shaw Khanam. I have the honor to work with Dr. Abbas Raza in 2010. The only example in my life of the word God gifted, only two people I met in my life. One is Dr. Abbas Raza, that is an example of God gifted teacher. And the second one is my youngest son, who is 8 years old, and he is so much talented. I give you one example of that boy. When Pakistan got defeat from India in this T20 World Cup, he told me one thing: Father, when I will be in Pakistan cricket team, I will not disappoint my nation.
Thank you. And again, it's humbling for me to hear these compliments when there are people who are sitting on the stage and sitting in front, Hamid and Khurshid and Ali and Amir. It's very humbling to hear that words from my side. But I must say one thing, and This is a side note. Having served in Pakistan Endocrine Society, what you said means a lot. And I probably represent the thought process of starting from our president who's sitting on the stage, that just the hall, which was half this filled, and it was not prepared to be opened on the other side because something else was supposed to happen, to open up that part and have a house full presence, and to have people who would wait for an year to be part of this Pakistan Endocrine Society. I think hats off to the executive committee, hats off to the even Dr. Jabbar is sitting in the front, who's probably the pioneer of it, and Dr. Tehseen is here in the audience. These are the people who made PES what it is. And again, people like Uniba and Amna and all the other youngsters who are here, Nadeem, who are presenting Pakistan. Thank you for being part of Pakistan Endocrine Society, and thank you very much for the compliment.
Thank you, sir. With this, we come to the end of this session. I would now request Dr. Uniba to come on the stage to moderate the next session. Thank you so much.